Welcome this afternoon. We are here with Ultimate Opinions in Medicine at our lung tumor board. My name is Mark Sosinski, and I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I'm joined by my four panelists. I'm going to have them introduce themselves. I'm going to start with Dr. West.
Hi, I'm Dr. Jack West. I'm a medical oncologist with a focus on thoracic oncology. I'm an associate clinical professor at the City of Hope Comprehensive Cancer Center in the Los Angeles area.
Hi there, I'm Kristen Higgins. I'm a radiation oncologist at Winship Cancer Institute of Emory University in Atlanta, Georgia. I specialize in thoracic malignancies, and I'm an associate professor and could be here discussing cases with everybody.
Hi, I'm Varun Puri. I'm a thoracic surgeon at Washington University in St. Louis, and I also serve as a professor in the department and the program director for our cardiothoracic surgery residency program. Glad to be here.
Hi, I'm Michelle Ginsberg. I'm director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center in New York City. I'm also vice chair of education in our department and professor of radiology at Weill Cornell Medical College in New York.
Our case here is a 61-year-old gentleman, a former smoker, but a 50-pack year exposure, has a history of unresectable neuroendocrine cancer of the right lung, who completed palliative radiation and is currently on palliative octreotide with stable imaging. So we want to talk a little bit about treatment options for this patient. Patient presented with cough, shortness of breath, some hemoptysis, said to have an excellent performance status, did have a past history of years ago of tuberculosis at a young age. Again, I mentioned he was a former smoker of 50-pack years, no significant family history. Dr. Ginsberg, do you want to review the CT scans for us?
Yes, we don't actually have the images, but it was reported as a large right-sided mass with associated collapse of the right lung. And there was also occlusion and really an abrupt cutoff of the right mainstem bronchus due to this mass. And it seems like the mass was really contiguous with the mediastinum and hard to separate from all the major structures like the pulmonary artery on the right and the trachea.
So the patient has an endobronchial biopsy. We're told it's a grade 1 carcinoid. I want to ask Dr. Puri a question, but maybe we should look at the PET scan first and have Dr. Ginsberg comment on the PET scan.
Right. So this is a dotatate PET scan, which is used in the somatostatin neuroendocrine receptor tumors. And you could see that it's very avid. That's the hot spot that we see on the right and in the right lung. And it's very good for these tumors, as well as also looking at bone lesions in the neuroendocrine type tumors, better than an MIBG SPECT scan. And on your other right-hand side is the corresponding CT, which demonstrates this mass, which occupies the entire right aspect of the lung. There's no visible aerated right lung, so it's all collapsed, and there's some calcifications within it as well.
So, Dr. Puri, what from this description, I know we don't have the CT, and we just looked at the PET as noted. What are your thoughts as a thoracic surgeon in this case?
I think putting everything else aside in terms of not knowing the exact anatomy, I can maybe make some sort of broad comments about a large neuroendocrine tumor which is involving the right lung. So since we discussed earlier that the primary modality for patients with carcinoid tumor remains surgical resection if it's achievable, then one makes a case for whether or not one would consider resection based upon the patient's operability, their performance status, their pulmonary function, etc., and the tumor's attachment or association or adherence to critical structures. There are some structures which we would really not consider resecting. So if one is doing a major lung resection, one would not consider resecting the esophagus or the trachea along with that if those are involved. So those would be things which we would shy away from. And in one of the descriptions, it was either adjacent to or involving the trachea. So that may be sort of surgical inoperability in terms of the tumor itself. But otherwise, if a large tumor is involving the entire right lung, then the loss of pulmonary function from a major resection, which might be a pneumonectomy, would be relatively modest if the lung is already not contributing any significant pulmonary function. So that's one thing that one takes into account. But again, it would be very important to really assess the imaging studies to see if this is resectable. There are times where we do take patients who are extremely healthy and otherwise good shape with very large tumors to the operating room. They may not have similar disease pathology as what is being shown here. And it's a mixed bag. There will be times that they will end up being resectable in the operating room, while there are times that you have to back out after making a large incision, after finding critical structures which are unresectable and not be able to remove the tumor. So unfortunately, without more imaging studies, it would be hard to make specific comments.
Yeah, I guess we're going to have to assume that that consideration was made, and the patient was not deemed to be resectable for, many of the reasons that you might have already cited, and initiated palliative octreotide every 28 days. We have a follow-up scan. I don't know if Dr. Ginsberg has any comments on the follow-up scan.
It sounds like it's essentially the similar findings are seen in this large mass with these calcifications, again, occluding the right main stem bronchus, and probably it sounds like it's extending to the carina. So essentially similar findings as what we saw in the other study. And subsequently, 5 months later, there was a CT which included the upper abdomen and demonstrated that there was progression of disease with development of new pleural-based nodules on the right.
Yeah, we're told the patient receives palliative radiation. Dr. Higgins, occasionally I have patients like this, or actually more commonly patients with mesothelioma that have, kind of a pleural-based lesion right in the area where they have pain. And I guess the question is, from a radiation oncology point of view, is this a reasonable strategy?
Yeah, I think so. Radiation is pretty effective at palliating pleural-based masses that cause pain. Now, the one difference here is that the histology is atypical, or actually this is a typical carcinoid.
Typical, yeah.
And they're not as radiation responsive as an atypical carcinoid would be, or a run-of-the-mill non-small cell lung cancer. So, and that being said, I've treated quite a few palliative carcinoids, and they do respond. You just don't see those brisk radiographic responses that you see with other more radiosensitive lung cancers. So you wouldn't really expect to see it melt away or go away, but yeah, you may see some pain relief. And that's generally my experience. And if we can use a hypofractionated approach, either with stereotactic, SBRT, or even higher dose per fraction, I would also advocate for that in this histology.
So Dr. West, we're told the octreotide was continued due to limited treatment options. You agree with that plan?
I would probably be more inclined to try a different approach if possible. I think that there are not great data. One question I would have, I'd be interested in your thoughts, the pathologic diagnosis, histologic diagnosis aside, this is progressing adenopathy, progressing disease. I am more inclined to base my decisions on what we're seeing in terms of natural history and the behavior of the cancer than what it says. I mean, to me, that's cold comfort, like, having right of way in a fatal accident. It doesn't matter if it says it's a typical carcinoid and it's not that threatening. That's no real consolation when it is progressing clearly and very clinically significantly. And so I would treat this, just as a neuroendocrine tumor. And we know that it is very avid on the lutetium dotatate scan, the PET scan. I would be interested in getting Lutathera therapy which is better studied and approved for GI neuroendocrine tumors, but has a clear rationale and is occasionally sometimes used individualized for patients with a pulmonary neuroendocrine tumor. That would be a leading consideration if feasible to me. Otherwise, if not, everolimus has been studied. It's not a crushing slam dunk, but it does have an associated improvement in progression-free survival that's been demonstrated in a randomized trial that included significant fraction of patients with pulmonary neuroendocrine tumors, generally after drugs like octreotide. And otherwise, chemotherapy can be used. It's all small series and more a proof of principle that you could use temozolomide or capecitabine or a cis or carbo-based regimen, and nothing that really bubbles up as a clear standard, but I think there's some other options out there. But to me, I think I just wouldn't fall to this is a typical carcinoid because that's what the biopsy showed. Clearly, the cancer wasn't reading that when it's doing what it's doing, or
Yeah, I agree with. I mean, obviously, the octreotide doesn't seem to be having much of an impact here, and I don't think we have clarity on best course forward here in terms of cases like this. I think you've kind of covered. I don't personally have any experience with Lutathera in pulmonary carcinoids. I do have some experience with everolimus and as well as chemo, and you can sometimes get some palliative impact on it, but like you said, it's certainly not a home run in these cases either. So you might consider a change. Given the fact that things are getting worse here, the patient is more symptomatic, requiring palliative radiotherapy, these sorts of things. But I don't know if you ask this question here, which is our last question here. I think we've kind of covered the bases, Dr. West. I can't think of any other options other than the ones that you've mentioned at this point.
Otherwise, just clinical trials, phase 1 studies. I mean, the standard answers, but there's not an obvious path here. That's for sure.
Right. So if we were to summarize that here, this patient, obviously, we would consider other options. We've discussed those options, but again, we realize that this is a difficult clinical situation where we need better options. And if there were a suitable clinical trial for a patient like this, I think that would be my first choice.